to the presenters.
Thank you for the introduction. So we're just gonna get started. Hi everyone. So it's Nadine and Trisha, and we're gonna be talking about decolonizing global health by mentioning the unraveling colonialism mentioned. We're students at Emory, and we're representing Emory's National Model UN Conference, and we will talk a little bit more about our conference at the very end of our presentation. So without further ado, Trisha, take it away.
So hi, everyone. Thanks again for the introduction, Manav. We really appreciate it. So first, we're going to go into a little bit more about like the history of global health and how has it like reflected and promoted colonialism. So before we can like begin talking about that, I'm just going to go over a little bit the difference between race and ethnicity. Race was traditionally defined as biological characteristics that distinguish people, and it was a way that Europeans would classify other races to justify their conquest of these parts of the world. So now we know that race has no biological basis and is just a social construct. But even though it is just that, the effects of racism have real world effects that are obvious and harmful today. Ethnicity, however, is based on shared cultural characteristics, including origin myths, shared ancestry, language, and religion. So colonialism really began with the age of exploration and with conquest. And over the 19th century, European business interests initiated these concerted search for like markets and trade routes by traveling all around the world and colonizing these people. So like colonization basically means like extending your rule over a foreign nation for extended periods of time. And there's many like different consequences of colonialism today that are incredibly obvious. So even like whole countries are colonial inventions, and many modern political boundaries in places such as West Africa or India were based on linguistic, political, and economic constructs which were promoted under colonialism. So what these like colonizers would do would like sow, an example, I guess, is they would sow distrust amongst tribes that were warring against each other, which even leads to like horrific consequences like in recent years, such as the Rwandan genocide. So the next point says like the white man's burden, which I'm sure like you've heard about in like your history classes or social sciences. And although like now we might think that it was kind of just this abstract term that we used to define this concept in the past, it was actually used a lot back then to kind of describe this like thought that like Europeans had as like they had this like responsibility, this paternalistic like responsibility to quote unquote take care of these nations that couldn't do it themselves. So it is like a paternalistic and racist doctrine which asserted that native people in colonized territories were incapable of governing themselves and needed guidance to civilize and quote unquote like Christianize them. And it was pretty widely used. So here like on the right, I just put like a picture of like an ad from even back then, which had like explicitly said like the white man's burden. And so this kind of burden was basically where the basis of global health and international health started, because it was this way that like these like white people would come and quote unquote take care of the people who were native to that land. So like from there, let's talk a little bit about like these cycles of global health and just kind of about different types of programming. So vertical programming these are interventions which focus on specific issues and solving them with modern technology and science, while horizontal programming focus on developing basic healthcare systems and strengthening them. And like from the 1900s to today, there have been a lot of kind of like back and forth in between these two different kinds of programs. So for example, in the 1900s, it was this first era of like colonial and international disease campaigns, which were meant to target like one disease while ignoring like other kinds of diseases that were there. So both like vertical programs and horizontal ones have like their own benefits and kind of like losses. So like one of the benefits of like vertical programming, for example, is that it like can focus on like diseases which might need a lot more care, but like it may overlook other like basic healthcare and other functions like that. While horizontal programming can be very expensive, but like overall develops the healthcare system of like a certain place. So here, like it kind of has been going like back and forth between horizontal and vertical programming. And now we're kind of in this era of more vertical programming with focus to like specific interventions and specific diseases. So some common issues and like effects of colonialism and also just this back and forth is that oftentimes these interventions are developed outside of the country where the health problem exists without input from the people who this intervention will actually affect. And in addition, it's like, as I was mentioning earlier, it can be more selective rather than like actually comprehensive and overlooks a lot of basic healthcare issues. And it also focuses on the application of biomedical technology like vaccines or other like technology instead of like hygiene and things that can have greater, broader effects. And planning often occurs after like a health crisis. A good example is COVID-19, where this huge pandemic occurred and we found that a lot of the world's healthcare systems were not prepared for it. In addition, interventions are often empowered by this faith in like the quote unquote superiority of Western knowledge and overlook traditional medicine and ethnomedicine that can be more effective and also just more, what's it called? And can be more like acceptable by the people who live there. And they also ignore the social and economic determinants of health, even though these have incredibly important effects for overall healthcare. So now I'm going to pass it over to Nadine.
Thank you, Trisha. And I'm going to be talking about the present and the future of global health and what a decolonized global health space could potentially look like. But first, let's talk about the present. There are three main things that I want you to focus on here, which is the concept of a complex power dynamic, patients and profits, and power, privilege, and priorities. In 2019, the World Health Organization published a report on global health financing trends that found as per capita health spending in African countries increased over the past 2 decades, so did the proportion of spending that comes from external sources. And the report also found that individuals' out-of-pocket payments accounted for the largest share of health spending, followed by donors, and government shares came in last. Donors provided more than 1/5 of health spending in 20 sub-Saharan African countries, and that's over 40% and over 40% in 9 other countries. While this is often marketed as a one-way flow of charity, in reality, this indicates a complex power dynamic that also yields benefits for the donor. So the donor is essentially benefiting here because it's related. So the donor establishes an incentive for that country to align its policies with donor interests. So ultimately, it is a complex power dynamic. And of course, such establishments influence health systems, in this case, in this example, in African countries, many of which have negative consequences. For instance, between 2003 and 2008, condoms were excluded from US-funded HIV programs simply because the Bush administration claimed that HIV prevention should emphasize premarital abstinence and post-marital faithfulness. Imagine that the Bush administration decided that and decided to ban giving condoms to HIV patients in sub-Saharan African countries. Without foreign aid, which often comes with unethical or unconstitutional clauses that further marginalize people, many health systems in Africa would completely collapse. And now in terms of patients and profits, building on what I just explained of the complex power dynamic, some aid providers conveniently decide to exceptionalize certain parts of human beings and only focus on those, as in literally focus on one body part and not the other body part, or some patients in a healthcare system rather than a general hygiene and healthcare of the entire country, the entire population. Imagine in Africa is through aid, and this aid doesn't cover all patient underlying health issues. Some coined a term for this concept as the philanthropication of healthcare. Also, a lot of biomedical advancements were done on the backs of Black people's labor, and scholarship, tests, and research were done on the bodies of Black people. Yet, they are often left fighting for the right to access these advancements, let alone profit off them. I'll give you an example. In a press conference that by Stella Emanuel, who is a US-based Nigerian doctor who recently declared that she has established an effective cure for COVID-19, a row of white men were standing behind her as if they doubted her work. White people stood behind a Black woman who has found a groundbreaking billion-dollar industry, claimed that she was the brains of the operation, and then took credit for her work that they initially doubted. And that's a pretty good leeway to the power, privilege, and priorities section, which is actually the name of a report that was published, where 85% of global health organizations were reported to be headquartered in Europe and North America, and nationals of high-income countries, which constitute over 80% of many organizations' leadership, health organizations' leadership. This leadership likely benefits from the frequent salary discrepancies between international and local employees, and by that I mean international employees that are from the United States or from Europe, or basically dominant white countries, that are working in sub-Saharan African countries, and there are discrepancies between those international employees' pay, salary, and the local employees' salary. And of course, the leadership benefits from these discrepancies. And that entrenches inequality within the very structures that claim to be tackling the problem with colonized global health. Even as priorities and approaches have evolved over recent decades, global health continues to take on ideas powered by the economic interests of formal colonial powers. But see, the future could be better. And a future in which global health is decolonized would be one in which there are no longer pervasive supremacist remnants of colonization within global health practice. But how can we achieve that? Slide, please. Today, global health is neither global nor diverse. And more leaders of global health organizations are alumni of Harvard than are women from low-income and middle-income countries, which I'm going to abbreviate using the term LMICs. Global health remains much too centered on individuals and agencies in high-income countries, HICs. Will global health survive its decolonization? Maybe, but a crucial first step is recognizing that global health was birthed in supremacy, and its mission is to reduce or eliminate inequalities globally. To transcend its origins, global health must become actively anti-supremacist and also anti-oppressionist and anti-racist. Supremacy generates funding, jobs, and training opportunities in global health. But rather than reenacting and reflecting the world back to itself in the fullness of entrenched oppression, global health must offer the world a better version and vision of itself. It must free itself from the persisting blindness of supremacy and embrace its alternative, which is equity and justice. Imbalance in authorships with partnerships between HICs and LMICs is a thing of the past. Journals have been transformed. Knowledge platforms are now decentralized and democratized. No longer exclusive, high-impact Western journals now exist among a multitude of go-to places, most of which are now based in the global South rather than the global North. In our reimagined world, the traditional mindset in global health, which is that expertise flows from HICs to LMICs, is a thing of the past. Many academic institutions in the global South are as influential as those in the global North, with a clear mission to serve the disadvantaged across both settings. There is no dependence, only mutual learning, and trainees from HICs are eager to study global health in LMICs to learn directly from experts who are closest to the problems and closest to the solutions. That means that local employees, which I was explaining earlier, in sub-Saharan African countries, for example, are just as credible, if not more credible, than international employees that are now living in that same area. Global health degrees are also accessible to those who need them the most and are taught by those who are there at the front lines, again, those local employees. It's a different world because reports of racism in global health organizations are mostly a thing of the past. And again, remember that we're talking about a reimagined world here. These organizations are no longer white-led, white-dominated institutions in HICs, but they've reoriented their operations to be closer and more accountable to the people that they actually serve. They're run by people who are local to the issues, and they have local knowledge because that knowledge takes preeminence in this kind of situation. They're run by people who are governed inclusively and responsibly, and these organizations now focus on organic change. They're not enablers, they're allies. Rather than seeing global health as charity or saviorism, or as Trisha mentioned earlier, the white man's burden, they seek to push for health as fundamental. practitioners and HICs and those who are otherwise privileged have embraced an appropriately modest view of their importance. And they've mastered the art of critical allyship, where they see their primary role as allies and enablers rather than complete leaders or puppeteers. Rather than drawing from a limited talent pool of elite HIC institutions, Black, Indigenous, and other people of color are the real leaders of global health in this reimagined world. In particular, women in the global South, who form the majority of the global health workforce, are proportionally represented in leadership. This is a future that we can only dream of, because we see many young global health practitioners who share these dreams. They're not afraid to ask uncomfortable questions or do uncomfortable things. Established global health practitioners must do better by to imagine global health anew. And I'm going to end this section with a quick quote. The goal of global health should not be to survive its decolonization, but to rise up and live up to the pressing demands of its mission.
And with that, sorry.
Go ahead.
So here are our sources. Feel free to peruse them, I guess. But with that, we're just going to move on really quickly and just talk about EndMonk a little bit. So EndMonk is our National High School Model UN Conference. As Manav mentioned earlier, it's October 15th through 17th. It is fully online and it is free of charge. Our Instagram is there, and so is our website. Registration hasn't opened yet, but it will soon. So please do follow our Instagram and just keep an eye on our website to know when that form is going to open up. We have some really exciting committees that we're really excited to bring to you guys. We have a committee that's based on Inside Out. We have a committee that's based on disarming weapons and privatization of weapons and things like that. So yeah, we really hope to see you there, and we hope that you enjoyed our presentation. I did receive one question, which was what determines if the health program being held is the vertical or horizontal one? So it kind of depends on how that health program is focused. So for example, a really good example of I guess a vertical health program is kind of there's a lot of different programs that focus on HIV. So then they'll specifically look at HIV and look at what kinds of interventions and what kinds of things, what specific education, sex education, and what give out condoms, and specifically antiretroviral therapy. So they'll basically focus on these three things for HIV, and then that will be the vertical kind of thing. But in doing that, it can overlook other problems, there's a lot of underlying determinants of HIV, for example, poverty, or even just a lot of comorbidities TB, cholera, etc. So a more horizontal programming would be to look at the hospitals and look at what specifically can be done to kind of I guess maybe if it's a rural hospital, how can we make sure that it has all the resources that it needs to treat different kinds of patients, not necessarily just HIV patients. And then in that way, it'll both improve HIV transmission rates, but it'll also improve the outcomes of other kinds of conditions. So I hope that answered your question.
Trisha, I just received another question. And the question is, you mentioned systemic racism in global health. So what do you think the UN/other bodies should do to achieve racial justice in the health system? And honestly, this might sound a pretty bold take, but I think that the UN and foreign bodies that were based in colonialism and supremacy should not be the ones dealing with discrepancies in the health system, because that's where a lot of the problems started. And we know, tracing back to before the UN, when it was just the League of Nations, we all know how that started with the end of the Second World War and the Treaty of Versailles, and how that immediately began, that immediately started separating people and I think that colonization also pretty much started somewhere around that time. But I think that to achieve true racial justice in the health system, there were a couple of things I mentioned about the reimagined future where people, Black, Indigenous, and other people that are working in the global south in the local countries, like, for example, I mentioned the example of the sub-Saharan African countries, where literally 80% or 85%, I think was the number, of healthcare is done through foreign aid. So it's not even, and the foreign aid organizations that provide healthcare to those countries are all inherently, like, have an inherent source of colonialism. And I think that immediately has an effect on systemic racism in that kind of environment. So instead of having the UN and other large bodies that often foresee systemic racism within the core and the fine print of their organizations, I think that companies in the global south that are now growing, and women and strong health practitioners and young people in the global south that are living on the front lines and being that kind of new source of leadership, are the people that can really reform and change the vision for global health to allow it to become more decolonized and to serve racial justice.
Awesome. On that very note, we have come to the end of this presentation. Thank you so much, Trisha and Nadine, for taking time off to conduct such a wonderful presentation. Definitely shedding light on a topic that has been hidden in the dark. Love the take on racism in the global system, in the health system, and how Nadine's take on what the UN or the other bodies, I mean, not the UN or the other bodies, whereas small local bodies should do to sort of combat that. Thank you so much. And to our wonderful participants, thank you for being so enthusiastic, patient, and interactive throughout the session. We really appreciate it. If you enjoyed the session, which I'm sure you did, head over to events.munimpact.org, where you'll find all the lineups of the other workshops for tomorrow, and be sure to attend them. And if you need any help or assistance of any kind, or have any queries about MUN Impact's programs, feel free to drop by the help desk. I will put the link of that in the chat box right now. And if you have joined late or have missed this amazing session, you can check out our YouTube channel, where you'll find the recording of this session. So subscribe to our YouTube channel as well. And finally, social hour is about to start now. So make sure to go to events.munimpact.org and RSVP for social hours right now. So thank you so much, everyone, and have a great day, or have a great rest of your evening.